Hello, and welcome to the Improved Healthcare Podcast. I'm your host, Rich Greenhill. Today, we're going to learn about the state of quality in Africa, perspectives from African quality and safety expert, Dr. Elom Otchi. Elom is the technical director of Africa Institute of Healthcare Quality, Safety, and Accreditation. He is a fellow and an expert in the International Society of Quality in Healthcare, FISQua, and a certified health surveyor. In Ghana, he has played various roles, including supporting the development of the National Quality Strategy and the National Patient Safety Policy. He has also contributed to the development of the Mother-Baby Friendly Health Facility Initiative Training Manual, which seeks to improve maternal and newborn outcomes. He leads the Quality and Patient Safety Program at the Korle-Bu Teaching Hospital. Dr. Otchi's educational accolades include a PhD from the School of Public Health, University of Ghana, master's degrees in public health and organizational development from the Kwame, Nkrumah University of Science and Technology, and the University of Cape Coast, respectively. He also has a bachelor's degree in public administration from the Ghana Institute of Management and Public Administration, and a diploma in medical laboratory technology from the University of Ghana. He's worked extensively across all levels of care in the health sector of Ghana. A warm welcome, Elom. How are you today?
Yes, I'm doing very great, and thanks for having me. Thanks for the opportunity as well.
Yeah, it's a pleasure to speak with you. So you're in the Accra region of Ghana, right?
Yes, I'm in the Greater Accra region.
Okay, how are things there today?
Yes, I think it's pretty exciting. The biggest news as far as healthcare is concerned in Accra and in the country is our National Health Summit, which is currently ongoing. It started from Tuesday and it's ending, God willing, tomorrow. So it's an annual summit that's organized and led by the ministry, and it pulls all the agencies of the health sector together, including partners, together to have various deliberations about the healthcare system and the issues that affect healthcare in the country. So that's the biggest thing now, other than COVID.
Well, that sounds very exciting. Not COVID, the actual summit. So
yeah.
So it's great to have you on the show. A couple things to set us up. So maybe you could begin by maybe a lot of the folks that listen in maybe have never been to Ghana. So could you tell us a little bit about the background of how the healthcare delivery system works in Ghana? Is it a national system, a regional system, or the like?
Yes, so Ghana's healthcare delivery system is organized. I think I would say we have a 4-tier. We have the national, we have the regional, we have the district and the sub-district. At the national level, when it comes to service delivery, the teaching hospitals are at the end point as far as service delivery at the national level is concerned. And there are currently 5 teaching hospitals in the country, but the biggest is the Korle-Bu Teaching Hospital, which is a 2,000-bed capacity hospital. And then we have the regional hospitals. So we have regional hospitals. Until recently, we had 10 regions, and we had regional hospitals in all the 10 regions. But now the number of regions have been increased to 16 administratively and politically. So other 6 regions are yet to have regional hospitals. And then we also have district hospitals. And then the sub-district, which is our primary, our base as far as health service delivery is concerned, we call the CHIPS compound. So at that level is community level. So these are community health posts or health facilities that are located in these health facilities. So in our health system, we also have the service delivery agencies. If you take the service delivery agencies, we have the Ghana Health Service. And the Ghana Health Service is the biggest agency when it comes to service delivery. And they manage secondary level facilities down to the least facility, which in Ghana we call the CHIPS compounds. And then we have the other service delivery agencies are the teaching hospitals, which I mentioned are 5 teaching hospitals. We have the Christian Health Association or the faith-based organizations, which is the Christian Health Associations, and then the Ahmadiyya or the Muslim-based organizations as well. And then we have the self-financing private sector that plays a very big role. In Ghana, the private sector, together with faith-based organizations, contribute, I think, on top of my head, about 25% of outpatient services in Ghana. And they also command close to about 45% of the healthcare service delivery in Ghana. So the private sector is a very big player also in the space. So if I say private sector, I talk about the self-financing private sector and then the faith-based organization. So this is what we have for service delivery. Then we have the regulatory bodies. We have regulation for infrastructure and regulation of personnel. And then we also have regulation for medicines and drugs. So for regulation of medicines and drugs, we have our Food and Drugs Authority. And then we have our Health Facilities Regulatory Agency, which is the regulatory body that licenses health facilities before they start providing service. And then we have professional practice. We have the medical and dental practice. We have the pharmacy council. We have the nursing and midwifery council, and then the allied health professions council. And we also have regulatory bodies for traditional medicine and practice. That is how the sector is organized in the country.
And how many people make up the country of Ghana roughly?
Population currently is about 30 million, according to the Ghana Statistical Service.
Okay.
Yeah.
So, wow. So you have a national health system that's mostly public and a percentage of it private. And that's interesting. Look, different from ours. Ours is mostly, we have public elements in our healthcare system, Medicare for our older population, 65 and above, and Medicaid, which is for people that what we call indigent or people that may have impoverished or whatever. So interesting. So you are the technical director of the AFICSA, the African Institute of Healthcare Quality, Safety, and Accreditation. Tell us about AFICSA and what you do there, what the organization is about.
Yeah, so before I talk about AFICSA, let me talk, because you made mention of Medicare and Medicaid. So our equivalence here is the National Health Insurance Authority.
Okay.
And the National Health Insurance Authority is our approach at universal healthcare coverage. People who are insured are able to access healthcare from accredited providers, either public or private organizations. We also have private healthcare insurance providers. And the public health insurance provider is the National Health Insurance Authority, or the National Health Insurance Scheme, which provides public health insurance, and facilities are free to get accredited or credentialed so that they provide healthcare service to insured clients who come to their facilities. So quickly on AFICSA and the African Institute for Healthcare Quality, Safety and Accreditation, it is our way of providing or bridging the gap as far as knowledge in healthcare quality and patient safety on the continent is concerned. Because until recently, if you would like to do any program or get any insight as far as quality and patient safety education is concerned, we would have to travel to places like where you are, Ireland and all the other advanced countries. Mm-hmm. This is our way of addressing the competency issues, because having worked in most areas on the continent, I see the will for improvement is there, but it is often the how and the knowledge for improvement that is often lacking. AFICSA is that stopgap measure to build competencies and capacity of the African, so that we are able to improve the quality of care that we provide. What is exciting about AFICSA is the faculty are Africans, and we understand our environment, we understand the terrain, and we know what works. It is not about somebody coming to tell us that let's do ABCD because ABCD has worked somewhere and we believe it will work here. There are context issues about quality. That is what AFICSA brings to bear. Fortunately, we've trained and built capacity for some Africans across the continent. We have a leadership for quality module. We have a patient safety module, which we have done over the period. We also organize annual conferences. Unfortunately, because of COVID, we have not done that. We did not do that last year. We are looking at whether we'll do a virtual conference this year. Maybe if we do, we'll invite you as one of the speakers. But so that is our uniqueness. But it doesn't mean we collaborate and work work with other organizations as well, because we know knowledge is very dynamic, and in this quality space, collaboration and cooperation is also key. And so as an organization, we collaborate with organizations like FISQua. We have a partner in India, BK Rana. We have another colleague in South Africa, Kosasa, Jackie Stewart. So we work with all of these people. We have other colleagues in, I think, Kenya. So we work with all of these people to see and to ensure that the average healthcare provider in Africa has some minimum appreciation and understanding of what the issues are and what skill sets are needed to contribute towards the improvement of care outcomes.
I think that's really amazing. And I'd love to come to Ghana when things clear up. It's a wonderful country. The key thing that you mentioned there is the context of quality. And I think that's one of the things, even here, that we see, what works in one facility, what works in one healthcare system, what works in one process is different, especially when you're thinking about culture, and the context of how to implement those things in the culture is so vital to making sure that A, you can implement it, and B, the intervention, and B, that you can sustain it. That's really awesome that you all do that in the Institute there.
Yeah.
So you've been a surveyor, you worked for WHO, and so what best practices have you seen across Ghana or the continent that have improved healthcare?
I think one of the best practices I see, having worked around and also working in Ghana, is the level of commitment and zealousness of the average healthcare worker. And it is very amazing the sort of environment, the context, and the places where the average healthcare worker works, and their levels of commitment is very amazing. And I believe that it is something that policymakers, partners should be able to capitalize upon for improvement, because will is the biggest thing. And once there is a will, there is always a way. And I see will and level of commitment of the average health worker, and that is one significant plus across the healthcare system. I currently supporting one of the departments of the University of Ghana, and we are working on this sprint project with UNICEF and the Ghana Health Service. So I'm just coming from the field, and some of the facilities we visit are about an hour and a half from the regional capital and about 3 hours from the national capital. And I see very young midwives, very young community health nurses, community health officers. And you see deprivation and the lack of facilities and the state in which they are providing healthcare, and you see their levels of commitment and zealousness. So if there is any positive and I have seen it in Sierra Leone, where I worked recently. I have seen it in Nigeria, in Zimbabwe, where I have some mentors, and across. The levels of commitment and zealousness is very amazing. I think what is often missing is policy and the disconnect with policymakers and the people at the front line. So if there is anything, and this is what Health Policy 101, oftentimes why policy does not often get the desired impact. We all study it as students of policy, but you finish and you practice, and it looks like we leave the theory in the classroom, and then when we are on the field, we do our own thing. So I think that disconnect is one of the biggest deal. But I always get amazed if it's maternal health. I see the excitement of midwives, 25 years, 22 years midwives in very remote areas. I think that is the biggest strength for us as a people and as a continent, as far as our healthcare is concerned. And it is one area that we can easily use as a launch pad for improvement.
Yeah, the culture is so important when you're trying to improve or do anything. And in projects I've led here, the culture can stop you can have all the policy and tools in the world, but the culture the culture meaning inside the organization, or the will, like you said. And so that's really fantastic that people are excited about improvement. And it's also wonderful that AFICSA is helping to build capacity to teach people the competencies for improvement. That's really great. So you mentioned that you were out in the field. So is that sort of translating into being in a rural space? How do people in rural villages there, or villages that are away from big cities, how do they get their care? I mean, are they part of the national health system as well?
Yes, so in Ghana, like I mentioned, so in the rural areas, we have what we call the CHIPS, community health planning, and CHIPS compounds. I've forgotten the full name. And then we have the health centers. So the CHIPS compounds are the least facilities. They are in the community, and these facilities are manned by community health nurses or community health officers. And then we have the health centers. So, and the health centers are a bit higher than the CHIPS compounds. The health centers are manned by what we call physician assistants. These are the various levels. So if you move from the health center, then you are going to the district hospital. We have and that is how our referral system is also designed. So as far as rural health is concerned, they are basically provided by the CHIPS compounds and then the health centers. What is amazing that I have seen is, and when I take the quality dimension, equity, I think that it is a very big gap when it comes to providing equitable care. Because, having worked across the health system, it is very amazing the level of variation when it comes to the provision of care. So, equity demands that if I am in Accra, and because maternal health is a big deal, if I'm in Accra and my wife has to deliver, and we go to one of the plushest facilities in the city, if we visit my grandmother in the village and she also has to deliver, there should be an equivalence of a facility in my village, if not even for infrastructure, human resource, so that, we get the care that we would have gotten. But unfortunately, it is not so. And even in the rural areas, you take the same district and there is very evident variation as far as quality of care is concerned. And I think for me, that is one key area that I think we are not doing well. As I talk about equity, another challenge has to do with the distribution of competent and qualified healthcare workers across the country. And that is also a very major challenge. Ghana has tried and applied so many policies to facilitate equitable distribution of healthcare workers across the country. But with the level of knowledge of rural practice that I see across the country, I think we are very far away from attaining the norm. Because the level of variation in care is not exciting at all. Anytime I embark on these trips and I come back home, it's you sort of lose a lot of steam and energy because we are blatantly flouting the equity dimension as far as healthcare is concerned in the country. But it is not only in our country. You see same, and this is not making an excuse for policymakers not to ensure that they are doing the right thing. But you see same across other parts of the continent as well. And I think it is something that we will have to double our efforts in addressing. Because if somebody in Accra deserves quality healthcare, somebody equally in the eastern region, in a place like Jekiti or Yongwase or those remote areas, equally also deserve quality healthcare. They have to be seen by the best doctors, the best nurses, and then provided in the best of environment as far as care is concerned.
Yeah, what I'd say is interesting because as you talk about equity, I think I had a guest on to speak about health equity in the U.S. And so health equity here is focused on several things. But typically when people think of equity, they think racially, right, or marginalized groups. Here in the U.S., there are issues that we share, like you, with the workforce in rural health, in rural America, right? It's the same type of thing, right? How do you recruit physicians, nurses, people to go to these areas? Because, if they're not near a big city, the pay may not be as good. And so there's all these issues. So I guess a key insight there is I didn't presume that you'd have the same types of issues, but your equitable issues are related to location mostly. That, how do you get the same level of care or type of care in a village that you have in a place like Accra or another big city. So key insight there that I hadn't anticipated. I want to go back to something. So you work at the Korabu Teaching Hospital. 2,000 beds.
Yeah.
What's the structure like there? So our hospitals here in the United States are run by healthcare administrators typically. I know from my time visiting the continent and other areas that it's mostly run by physicians. So would you talk a little bit about how the hospital is structured and what might one expect if they go into a facility?
The hospital structures here, so you take a typical teaching hospital, and this is not only the Kolebu Teaching Hospital. They are run by chief executive officers. Oftentimes, the chief executive officers are medical doctors. I mean, once upon a time, the Kolebu Teaching Hospital experimented with a non-medical doctor as the CEO, but that rarely happens. And it is the same also in the regional hospitals and the district hospitals. And then there are health service administrators. So you take a typical teaching hospital, you have the CEO, their management will be made up of the CEO, who is the lead, and then you will have directors of human resource, director of administration, general services, and then medical affairs director, who is also a medical doctor. And then you have a director of nursing, who is obviously a nurse, and you have a director of pharmacy. So that is how a typical teaching hospital is run. And it is often doctor-led or physician-led, so our healthcare system is often doctor-led or physician-led. I don't want to get into trouble because of the various audiences that that would be listening. But I think by and large, it has contributed partly to some of the challenges that we have. Because you take a typical physician training, there is very little they do as far as leadership and management is concerned. Leading people, managing resources, managing organization. This is a skill that people go to school to learn. But I think in our part of the world, we think that because the doctor or the physician is the leader, even when he or she doesn't have the necessary competencies and skill set to run and lead an organization, he or she becomes the obvious and the first choice as far as some of these roles are concerned. And I mean, it is, and I dare say it has partly contributed to some of the chaos that we have as far as our healthcare delivery system is concerned, because the literature has showed us all over the world that physician administrators have not been the best or some of the best administrators we have over the period. You take leadership in even some of the departments, and I'm not making any specific statement to any hospital, but leadership even for heads of departments in some of the hospitals is a big deal, and we entrust them with leading and running very huge and humongous organizations, and at the end of the day, they don't tend to make the desired impact as far as leading some of these institutions is concerned. But maybe let me quickly say that, I mean, I have seen in my lifetime some of the best physician leaders, both in Ghana, especially in Ghana and elsewhere, some of the best physician administrators as far as healthcare organizations are concerned, and they are making very huge differences and impact. My mentors, name some of my mentors like Dr. Buckle, who led the Christian Health Association of Ghana and transformed that organization, and then did so in the Kolebu Teaching Hospital until the end of his tenure. And then another like Dr. Emmanuel Sropenyo in the Greater Accra Regional Hospital, who is also making a very huge difference as far as providing the necessary leadership in that facility is concerned. But hey, these are very few in the midst of the big pool. And I think we may have to reconsider some of the people, especially allowing physicians to lead healthcare organizations, because I mean, evidence shows that they are not necessarily the best. And we also provide an opportunity for other cadres and other people in the healthcare delivery system who are very knowledgeable and insightful and have the requisite skills and competencies to provide the requisite leadership for some of these healthcare organizations. I mean, it's about providing opportunity and a leveling playing field so that it should not necessarily be that you are a physician and it becomes a right because you are a physician to lead a healthcare organization, even when it is obvious you don't have the requisite skills and competencies. I know this view is going to put me into trouble, but
Well, what I'd say, as we get ready to wrap up, what I'd say is that you're right, actually. And so as a professor, I teach students health administration, right? And we teach people the foundations of leadership. And then via our professional organizations here in the U.S. and it's international, the American College of Healthcare Executives, for example, they have programs where we teach, people how to lead, because you're right, it is a skill. It's a very, very good and valid point that it's a skill that you can train, but, you don't come out of medical school or pharmacy school or nursing school ready to lead, right? Because that's not what they teach you in those schools. So it's a great point. So, well, I want to just thank you for taking time out today. I certainly have learned a lot, and I know that our listeners will as well. And I appreciate you sitting down, and I hope that when things clear up from COVID, that I'm able to make it across the water there to visit and see some of the great work that you're doing. So I appreciate you taking time today.
Sure. Thank you too. Thank you very much.